I'm Danny Davis, Vice President of Clinical Operations here at Valley Children's Healthcare. I oversee a large area of the hospital that includes the inpatient setting as well as a lot of ancillary services such as home care. Those areas are crucial areas in our hospital to support the clinical needs of our patients. Part of our main focus is providing safe quality care to our patients in our catchment area, as well as providing care where they live. So up and down our valley, we're able to provide care within about 30 minutes from a patient's home. With that comes a lot of standardization in our processes to make sure that the care that we're delivering here at the hospital is the same care that families, as well as our providers and referral sources, will see and experience at their local entities or their local communities.
I'm Leanne Kozub. I'm a registered nurse here at Valley Children's Healthcare. I've been here 18 years and I am the nurse manager of patient safety and risk. In 2014, Joint Commission issued a Sentinel Alert number 53 that talked about connectivity issues that other hospitals were having. It allowed us to have a framework for a gap analysis for our organization to look at our risk. And we found that we had an organizational problem that affected every unit. The opportunity to start this gap analysis allowed us to assess our connectivity issues and got us to the point where we realized we needed to implement ENFit sooner rather than later. At the same time that we started rolling out ENFit, we started working towards becoming a high reliability organization. We are teaching error prevention across the hospital. ENFit fit right in with that on how we are trying to prevent errors from happening and events from happening that impact patient safety.
I'm Chris Aubrey. I'm the director of the neonatal service line here at Valley Children's Hospital. And my role in ENFit really had to do with coming into our value analysis team, which is where we evaluate new products, and recognizing that we were 6 months out from a state regulation that was going to have us change our enteral feeding products. And being the largest user of the products that we use in the hospital here in the neonatal intensive care unit, I became alarmed a little bit because I was concerned that we didn't have a real robust plan in place to be able to address that conversion. We were 6 months out from having this conversion occur and we needed a plan. And all of a sudden I felt the weight of how we were going to move our organization, but the NICU specifically, into using enteral products, and I didn't know where to begin. And it seemed like we weren't sure exactly of the impact. We had discovered that we had done an assessment, but it hadn't necessarily trickled down to each one of the departments to understand that. So what was the supply look like? What were the options out there? How many different products did it touch? How many different products did it touch in different units? And what did my staff need to be able to make this conversion? What would the product look like? And those were all questions that we weren't sure about. So with that plan, we really brought a team together.
My name is Angela Hill, and I am the Value Analysis Clinical Care Coordinator for Valley Children's Healthcare. So when we decided to develop the hospital-wide team, we really wanted to look at the products, the enteral products, who was impacted, to determine who needed to be a part of the team. And in looking at that, we chose several clinicians, physicians, surgeons, case managers, ancillary departments that are also impacted, your dietitians, as well as key clinician staff, nursing, and some of our clinical areas that were also going to be impacted by this change, to really try to grasp our hands around what was going to happen and what we needed to do. As we've gone through the ENFit implementation, there were really 4 key elements of our implementation that really helped, I think, make our hospital Stay Connected Task Force team successful. The first one being the identification of the product. By identification of product, the first thing that we really had to do to understand the ENFit implementation was to understand what products might be impacted by that. So we needed to look throughout our internal system to identify all the products that we use that could possibly be impacted by this ENFit implementation. Once we identified the products, we needed to make sure that we had a crosswalk to the new ENFit product. So when we were ready to make the transition, we had the new product ready and available for staff to use. As part of the ENFit implementation, we were going through the transitionary period. There were new pieces that we also needed to bring in, and we also had other transition connectors that needed to be in to support the transition between the legacy style products and the new ENFit products. Our second key to success for our hospital task force team was the identification of the impact, and I think this really helped us identify who needed to be a part of the team. One, it was really looking at who was impacted by this change, what kind of policies or practices may need to be revised or implemented as part of this change, and then really identifying the resources that were needed to support the change. The third key to the success for our implementation of the ENFit was really around our communication. Not only just our communication to our staff, letting them know that this was coming, what they needed to know about the change, but also to our patients and families and how it would impact them, as well as our patients that are followed by our home health. A key part of that during the supply chain transition was communicating well with our manufacturers on the changes that we were making sure that we had enough supply demands with them, providing them our usage so they could meet our needs, as well as our distributors, and really having weekly and sometimes daily conversations with them on where we were at with getting supplies. And then just having a backup plan for, if something changed or something needed to be communicated to, then we were able to adjust and make that happen through the communication between all of those people. The fourth key to our success, I think, was the follow-up that we continue to do as part of our ENFit implementation. Some of it is identifying any issues that we may have had as part of the transition, identifying what the particular issue is and what we need to do to resolve it. Some of it is doing a wrap-up of how well did we make this transition work, what can we learn from it so we are prepared for the next transition that we have to do. And then finally, just being flexible. We had the best laid plans that we could, but as you know, as you move forward with product conversions, nothing ever goes smoothly. And so being able to be flexible and rethink how you handled things so that way you can come up with a different solution if you need to and move forward so that way your implementation can be successful.
I'm Steve Wade. I'm a pharmacist here at Valley Children's Hospital, and I was the lead pharmacist on our Stay Connected committee that brought in the ENFit products to Valley Children's. So the first consideration we tackled was how we were going to onboard ENFit products into the organization. Like everyone else in the business, we were using a single conventional type of oral syringe for both oral and enteral medication administration. So the first option we considered was we'll bring in ENFit syringes for administering medications to feeding tubes and retain use of conventional oral syringes for the oral route. And then the other option we considered was consolidating the use of product and process to just ENFit syringes. In other words, using ENFit syringes for both oral and feeding tube medication administration. And we ultimately came to that conclusion and selected that option because of the benefits we recognize in terms of patient safety, inventory management, and pharmacy operational simplicity with using a single product. The second consideration we had was getting institutional and executive leadership buy-in for the proposal to consolidate oral and enteral administration to a single product. And that was a relatively easy thing to do. We had executive participation in our group that made the decision, and it was a matter of networking with my director and the directors of the various stakeholder departments to explain what we felt were compelling advantages and benefits in terms of patient safety, inventory management, pharmacy operational considerations, and even bedside operations in terms of how the nurses were going to use these products to give ventral and oral medication. So in the end, it was a fairly easy and quick process. We didn't really get any pushback from senior leadership on the decision. The third big consideration was how we were going to partner with other stakeholder departments and entities within the organization to onboard this product efficiently and safely. We recognized early on that pharmacy and nursing, particularly nursing education, had to collaborate to produce good educational material and processes. We had to collaborate with our supply chain folks to coordinate onboarding and phasing in of these products as we phased out our old inventory. And we had to have a lot of discussion within the pharmacy on how, at a fairly granular level of how, when it came time to use these products, how are we actually going to use them? What do they feel like? How do the new caps fit on the syringes? How do the various other components work and feel? And so we also knew that that benefit of hands-on experience also extended to nursing, and probably especially nursing.
My name is Raymond Sotelo. I am the Materials Distribution Supervisor for Valley Children's Healthcare. I manage a materials distribution department that is responsible for the distribution of supplies throughout the hospital. From a materials distribution standpoint, we decided to go through a soft conversion, meaning that we were going to deplete existing inventory of product we were switching out, and then as that depleted, we were going to transition the ENFit product in its replacement. However, during that period, we needed to keep existing stock of product here to address any needs from any of our outside customers coming into the hospital, or even being able to adapt to our home care customers who had existing products that would not necessarily convert completely to the ENFit product. We were brought in roughly July of 2016 to coordinate the physical transition of the ENFit product. In those 3 months, we identified inventory levels with not only our own warehouse, but working with our primary vendors to establish their inventory levels. We educated the team, we created a group that would actually be part of the implementation, and by October of 2016, we were fully engaged in the actual physical transition of the ENFit product.
I'm Jean Holscher. I'm a clinical ed specialist, and I sat on the ENFit team to help plan the education for the facility. To begin the process of deciding the education we needed, we use a tool that we designed here called the COMA scale, and it identifies how complex the change in education needs are. We knew we had a lot to do because it really impacted so many people in different areas. So after we did that, we identified that on a scale of 1 to 10, our complexity was an 8. So that began to say we need to begin to do multiple different education methods. And those methods included some traditional and some not traditional. So one of the non-traditionals was the PlayStation that we designed, which was a way to get staff to be able to see, learn, and put their hands on the new materials and supplies that supported ENFit. So what it was a poster board with just-in-time, step-by-step materials, as well as information about what was going to change. And then it had an attached box to it that had the supplies so staff could actually put their hands on the syringes and tubes and manipulate them before they ever saw them with a patient, which greatly reduced some of the concern about what was going to change in their world. The second thing we did for training was create just-in-time sheets. And these are one-page sheets we put together for many new items, including the ENFit oral syringes and enteral syringes. 3-step process with pictures, how you do it. That was available both at the PlayStation and in medication rooms and other places nurses might want to look to have a resource. The third tool that we used to provide education and knowledge to staff was online modules that are part of a quarterly update we do. And there was always information in there that ENFit was coming, why it was important, it was patient safety focused, whatever we had in terms of latest content at that moment. The fourth tool we used was 1-minute videos. When issues came up and we needed to provide staff with a little more information, one of our educators in our department is a videographer on the side, and she did quick 1-minute videos with the step-by-step. We posted them on our internal website and staff could go there and review. So as a result of the educational methods we used, we were able to reduce staff stress level about the changes and speed the adoption of the ENFit into our organization.
If I had any advice to give fellow NICU directors, it really is involving your team members, the direct end users, to have them come and show you how they're using the product. We had a lot of assumptions or thoughts of how it would be done or policy, and that's where we discovered that we had sort of what we call workarounds or deviations from what we thought the practice was. So they showed us, and we created a safe environment so that they could show us how they were using the product, why they needed to make those changes, so then we could evaluate how we could address those concerns or those needs in our patients.
There's a lot of lessons that we learned throughout this ENFit implementation that we can take forward and moving towards the next task force that we have to develop for the next small bore connector change. Some of those are around our supply chain and ensuring that we had at least probably a 3-month estimated usage between not only what we wanted available in inventory within our hospital, but also the manufacturer and our distributor, as well as the education and things that we needed to put in place prior to the transition on the clinician side. There were several learning points that we did, and we were excited to move forward with those for the next one.